move forward. We're going to continue to talk about alcohol. As I mentioned, we're specifically looking at medications that we use for alcohol use disorder. And so this is different than what we've looked at previously, where we looked at detoxing someone or getting someone through the initial withdrawal period for alcohol. These are medications used after that point. And so these medications do not replace the need to appropriately detoxify or withdraw someone off alcohol in situations. So these are not these are not sufficient. So some on their own to protect individuals from those negative consequences of withdrawal, which we've talked about. I have no disclosures. Objective-wise, you can see we're going to provide a brief overview of medications approved for the treatment of alcohol use disorder, specifically those that are FDA approved. And then we're going to discuss the clinical use of two of those options, Disufiram and Acamprosate. Next slide, please. Go back two more. So there are 3 medications approved by the FDA to help in either reducing or ceasing alcohol use in individuals. The oldest of these options is called Disufiram. The old trade name for it was Antabuse. And it's considered an alcohol sensitizing agent, meaning it makes individuals sick when they drink on it, so they become more sensitive when they drink alcohol physically. And then there are medications that are designed to directly reduce alcohol consumption. One of those is naltrexone, which we're going to talk about more in a couple of weeks after the break next week from ECHO. And it comes in 2 different forms. It has an oral form and an injectable form. And so some people will call those 2 different medications, but it's the same parent drug. It's the way it's administered and given in the bodies differently. And then today we're also going to touch base about a medication called Acamprosate, which the old trade name for it is Camprol. And it's been generic now for at least a few years, still quite pricey. I've actually run into some price issues with Disufiram as well, interestingly enough, just because it's difficult to obtain. Most pharmacies don't keep it, and therefore there's a small market for it. And I think at a patient paying cash price, you ended up paying close to $100 for a medication that's 50, 60 years old, or more than 50 or 60 years old, which is always interesting to me. Next slide, please. We're going to start talking about Disufiram first. And it was approved in 1949 as an aversive medication for the treatment of alcohol addiction. And back in the 40s, they were not required and really didn't do double-blinded placebo-controlled trials. And so Disufiram was approved on a series of cases, basically, or positive responses in clinical settings. So to this day, you don't see a large study like you see with a lot of the newer medications available. And Disufiram works by irreversibly inhibiting an enzyme in your body called it's called acetaldehyde or aldehyde dehydrogenase. And it is a enzyme that's responsible for helping alcohol break down in your body. And the enzyme right before this, which we'll look at in a minute, breaks alcohol down into acetaldehyde. And then this enzyme that Disufiram is inhibiting, acetaldehyde or aldehyde dehydrogenase, is blocking the breakdown of acetaldehyde, causing the accumulation of acetaldehyde in the blood. And I keep saying aldehyde dehydrogenase or acetaldehyde dehydrogenase because they're the same enzyme, and you'll see both names mentioned in textbooks. So I sometimes get that in my head saying one way or the other for a bit. Next slide, please. This is what I talked about showing you the specific mechanism of action. So you can see when alcohol is ingested, it is broken down, as we talked about a few weeks ago, primarily by these enzymes. The first enzyme in the step is called alcohol dehydrogenase, and that turns alcohol into acetaldehyde. The second enzyme is aldehyde or acetaldehyde dehydrogenase, which converts acetaldehyde into acetate, and then acetate then enters the Krebs cycle and is utilized as a product of the Krebs cycle. And so, as you can see from this slide, we have disulfiram working on that second enzyme, inhibiting it and preventing the breakdown of acetaldehyde. And that's what leads to the toxic, or not toxic, but yeah, really a toxic, but a buildup of acetaldehyde and the reaction that we see with that. Keep in mind there's an antibiotic that also blockades this, or it's an antimicrobial, pardon me, that also blockades this or destroys this acetaldehyde, and it's called metronidazole. So you always want to tell your patients that you prescribe metronidazole, which is usually, I believe, for more parasitosis. But for those who do this more often than me, can correct me if I'm incorrect, but they use it a lot for amoebas, and as well as, I think, bacterial vaginosis, at least when I was last doing that kind of medicine. Next slide, please. The reaction, by accumulating acetaldehyde, you get this disulfiram ethanol reaction. And that reaction results in warmness and flushing of the skin, particularly upper chest and above. So people will notice it more prominently, kind of from the pecs up into the head. It can also lead to increased heart rate and palpitations. It can lower the blood pressure, cause nausea and vomiting, which is something people notice usually pretty quick, as well as the sweating. It can cause shortness of breath, dizziness, can affect your vision by causing blurred vision. In more extreme circumstances, it can lead to confusion in there and potentially even death, and if high enough volumes of alcohol are consumed to the point where your blood pressure crashes. So severe reactions can occur, and these severe reactions, tends to be preceded by tachycardia and hypotension that become more pronounced. That could lead to cardiovascular collapse, heart failure, and seizures in some cases. The intensity of the reaction is going to vary with the volume or the amount of alcohol that someone is ingesting. So if we have the enzymes inhibited, the more alcohol we drink, the more acetaldehyde buildup we get, and the worse the reaction. Most reactions are going to be self-limited and last about 30 minutes. Your body finds other ways to eliminate the acetaldehyde, but it takes it time to do so. Next slide, please. Clinically, it comes in oral medication in the United States. I know you can get FDA-approved oral medications. I know in other countries they can do implants of disulfiram or disulfiram. I've not seen those in the United States. If they're there and you guys know about them, let me know. It's kind of can be cruel. I know in Russia it can be a legal implementation to for if you have alcohol use disorder to implant disulfiram. Available tablets that are on the market are in 250 and 500 milligram doses. It's generic. It's been generic for many years. And practitioners will usually dose it somewhere between 125 or half of a 250 milligram tablet a day, all the way up to 500 milligrams, depending on the response that they're hoping to get. So if you give your patient 125 and they drink on it and they don't get very sick, that may lead you to want to increase to a higher dose. That would be an example. Common adverse effects include tiredness, lethargy, and fatigue. And this is not counting, of course, the reaction you get with alcohol. These are just direct adverse effects from the medication itself. More seriously, but less common, are hepatotoxicity. So it can lead to liver inflammation and worsening of liver status, optic neuritis, which is like neuropathy of the optic nerve, and then also peripheral neuropathy. And keep in mind that disulfiram does other things besides block that enzyme. It actually inhibits another enzyme called dopamine beta hydroxylase. And dopamine beta hydroxylase is responsible for breaking down dopamine, metabolizing it so if you have individuals who are prone to psychosis, so like individuals who have schizophrenia or severe bipolar disorder, you're going to use a lot of caution and probably not prescribe this medication to them because it can worsen mania and psychosis. Next slide, please. The enzyme itself is destroyed or irreversibly inhibited by the medication. And so once the medication works on that enzyme is dead. Essentially, it's ineffective. But your body is constantly making new enzymes, and so it's not going to be a permanent situation. But it takes about 14 days to get your body back to a steady state of these enzymes after the medication has been stopped. So it's about 14 days to rebuild, basically. It's recommended that you advise your patients to discontinue all alcohol-containing products, and that can include things you may not think of, like mouthwashes. So a lot of mouthwashes have ethanol in them, so you want to instruct your patients to use a non-ethanol based product if they're going to for their mouthwash. And Listerine Zero would be an example. Zero is the zero alcohol. It uses another topic that won't, or it uses other sugar alcohols that aren't ethanol, won't utilize, won't cause a reaction, I'm sorry. Because of the risk for hepatotoxicity, we do want to get LFT labs or liver function tests in individuals that we are treating with Disufiram. And so they recommend baseline, so prior to starting the medication, and then every 2 weeks for the first 2 months, followed by every 3 to 6 months thereafter. And I know a lot of clinicians don't do it this frequently, but this was taken out of an article, a more recent article, more recent being like 10 years ago, which is recent for Disufiram, on how, what was a kind of a consensus on when to check liver function tests or liver enzymes. You also, because of the risk of optic neuritis and peripheral neuropathy, you want to be providing monitoring for that. So look for visual changes or sensation changes in extremities. Next slide, please. This slide just shows you abstinence rates for treatment in a small study for those who were adherent and non-adherent to Disufiram. So I think the biggest point is to look at the left side. So you would have a group of individuals who were given 250 milligrams of Disufiram, 1 milligram of Disufiram, or placebo. They were educated on what happens if you drink on Disufiram, and then they took the medication home and were instructed to take it. And so you can see that on the left side, those who were non-adherent, meaning they just didn't take the medication, had no significant change in abstinence rates. And so rather they got the placebo or the real thing, or the full dose of 250 or the very small dose of 1 milligram, patients just did not, who fell in this group, 80% of them, unfortunately, just chose not to take the medication, which is what we see clinically in many cases. When we do prescribe it, people just choose not to take it because they know drinking can cause some negative activities. On the flip side, if you go to the right side of the slide, you can see in those individuals who were adherent, 20% of individuals in the study, that they didn't drink very much. And that was just the fear of having the reaction will drive some of your patients not to drink while taking this medication, but many just won't take it. Next slide, please. We're going to transition into Acamprosate, or what used to be called Camprol. And this slide is a review from several weeks ago, just kind of reminding us all of some of the molecular sites that alcohol acts on in the brain. And the one we're going to pay attention to is MDMA glutamate receptors when we're talking about Acamprosate, because when we drink alcohol, those receptors are antagonized or blocked. And that's our excitatory neurotransmitter in our brain. And so we're getting blockade of activation in our brain when we drink alcohol. We also get, of course, enhancement of disinhibition or deactivation because of the GABA effects. Next slide, please. So acamprosate was approved in 2004. It was as a treatment to maintain abstinence from alcohol use. It is an amino acid derivative. It has a complex mechanism of action. It's designed to decrease alcohol cravings and urges. And we don't completely understand the exact mechanism of action, but more recent research actually has led us to a little bit different thought on how acamprosate might work. So we traditionally thought it was an antagonist of the MDMA glutamate receptor. And the thought was that when you take acamprosate after you quit drinking, we're blocking this glutamate, and it's making our brain believe that we have alcohol on board, therefore we're not, by balancing those neurotransmitters, and therefore we're not desiring to drink or crave to drink as much. But more recent research suggests that it's actually a partial co-agonist. So complicated concept means it's a partial agonist, so it can partially activate the receptor, but it's also a co-agonist, meaning that it also requires other binding substrates to activate the receptor. And it's thought that by having this co-agonist and the partial agonism at once, that the acamprosate is enhancing glutamate receptors when there's low glutamate in the brain, and it is inhibiting glutamate receptors when there are high levels of glutamate in the brain. So it's still trying to get the brain back to a steady state of glutamate, but the effects of this may change based on how much glutamate is actually in the brain. So whether it's enhancing or inhibiting could potentially vary. And again, we're still learning the full mechanism, but that's the most recent thought on acamprosate. Next slide, please. It's administered in oral tablets. They come in 333 milligram tablets. The typical dose is for 333 milligram tablets 3 times a day, or 1,998 milligrams per day. Acamprosate is renally excreted and has no hepatic metabolism. So it's going to be different than the other 2 FDA options of Disufiram and naltrexone, in that those both require hepatic metabolism and have some risk of causing inflammation of the liver. And so you don't have that with acamprosate. So if you have an individual who has significant liver impairment, this would be a safe option if it's effective. And the manufacturer recommends starting the medication 5 days after the last alcohol use. So this became a sticking point when we look at the combined study. When we look at the combined study in a couple of weeks, we'll look at why this became a sticking point. Next slide, please. The most common side effects are diarrhea, bloating, and itchiness. I've seen diarrhea and bloating. I'm not sure I've ever seen itchiness, or I've not had a patient complain about it. There is no dosage adjustment needed for liver impairment, but there is a renal impairment dosage recommended, and that's to, instead of taking 2 tablets 3 times a day, to reduce it to 1 of those 333 milligram tablets per day, in order to because it's going to accumulate if there's renal excretion issues. As you guys might imagine, 3 times a day dosing can limit compliance in individuals. It's really difficult for me. I don't like getting some of the penicillin-based antibiotics because they want me to take them 3 times a day. I can do really good in the morning and the evening because I set it by my toothbrush. But at work, I sometimes forget because I'll get busy. And I think other people have that same issue with 3 times a day medications. And acamprosate's not alprazolam. They don't feel it, so they're not going to be as the brain's not going to be rewarded when they take it, and they're not going to be at risk of coming into withdrawal when they come off of it. So there's less reminders in your brain to take it. And you can safely combine acamprosate with disulfiram as well as naltrexone. And I've done so particularly with naltrexone before, sometimes have some benefits. Next slide, please. All right, that's the last one. Any thoughts, comments, questions?